Well, I will get things started. If anybody else pops up, we'll let them in. I get the impression that most of us, or most of you all know each other, and I know many of you. But to start with the formalities, I'll introduce Dr. Celine Larkin from the University of Massachusetts Medical School. Celine Larkin, PhD, is committed to understanding and preventing suicide and other mental health conditions. Dr. Larkin obtained her PhD in health services research from the University College in Cork and her postdoctoral fellowship in implementation science from the University of Massachusetts Medical School. As a junior faculty in emergency medicine, she draws on the fields of psychology, health services research, and implementation science to investigate better ways of identifying and responding to mental health needs in diverse healthcare and community settings. Her topics of interest and experience include suicide, depression, tobacco and alcohol use, and as an emerging investigator, she seeks to continue this trajectory by leveraging evidence-based strategies and emerging technologies such as machine learning, computer-based learning, and stuff that didn't show up on the rest of the thing.
Don't worry about it. Kind of that important. Thank you.
So joining us is Dr. Sean Michael. He is currently the Emergency Department Medical Director at the University of Colorado Hospital and the Fellowship Director of Emergency Medicine Administration, Operations, and Quality Fellowship at the University of Colorado School of Medicine. Raised in Denver, Colorado, he attended medical school at the University of Colorado and then completed emergency medicine residency at Detroit Receiving Hospital. He attended fellowship training in administration, operations, and leadership at the University of Massachusetts, where he also earned an MBA. His research interests focus on ED and hospital crowding, patient flow, and provider behavior change, particularly around high variation research utilization and opioid prescribing. He is also board certified in clinical informatics. And then finally, Dr. Martin Resnick, MD, MBA, is a professor and vice chair for clinical operations and education in the Department of Emergency Medicine at the University of Massachusetts Medical School. He also serves as the founding director of the Richard Agababian Emergency Medicine Leadership and Administration Fellowship at UMass. Dr. Resnick earned his doctorate of medicine at Baylor College of Medicine and his MBA at the University of Michigan. He completed residency at Detroit Receiving Hospital, Wayne State University School of Medicine, and he has completed 2 fellowships, one in simulation at Stanford University School of Medicine, and a second in EM hospital administration at the Detroit Receiving Hospital, Wayne State. In addition to his administrative duties, Dr. Resnick remains active in research. And I will let you guys kick it off.
Thank you. So hi, everyone. Good evening. It's really nice to be here. It's my first time at SAEM. It's virtual, but I'm here in spirit. So today we're going to talk about audit and feedback as an implementation strategy. We're going to work through 2 sort of case examples of how we applied audit and feedback in a randomized controlled trial fashion for changing clinician behavior, and 2 different outcomes for 2 different clinician behaviors, and talk a little bit about the theory and where audit and feedback fits into the larger field of implementation science as well. So just to say that we don't have any conflicts of interest. So the learning objectives for the didactic today are to define audit and feedback, to describe the evidence for the effectiveness of this strategy, and to articulate circumstances in which audit and feedback might not actually be very effective in changing clinician behavior and might actually have harmful effects. So we're going to talk through audit and feedback as an implementation strategy, present these 2 randomized control trials of audit and feedback. The first to reduce opioid prescribing, and this is from a published paper, and the second to reduce CT ordering, which is a paper under review at the moment, and then talk about some implications for practice. So Dr. Michael is going to walk us through the opioid prescribing piece, and Dr. Resnick is going to walk us through the CT ordering. So just to kind of ground audit and feedback in the field of implementation science, which is my own sort of background. So audit and feedback is a type of implementation strategy. So a strategy in implementation science is a method or technique used to enhance the adoption, implementation, and sustainability of a clinical program or practice. So that could be an intervention or another sort of evidence-based practice. And Proctor and colleagues in 2013 did a expert consensus process to identify distinct implementation strategies from the field. So there's a bunch of different implementation strategies across different domains. So for example, using evaluative and iterative strategies include examples like assessing for readiness, audit and feedback, and re-examining the implementation. So anyone who's familiar with sort of continuous quality improvement strategies will see a lot of those being echoed under these evaluative and iterative strategies. There's also a number of other domains, so adapting and tailoring to context, training and educating stakeholders, kind of a perennial implementation strategy that we'll probably turn to first. Engaging consumers, so increasing demand for a new practice or intervention, and engaging patient and family, patients or consumers and their family members. There's also a lot, I think, within quality improvement that focuses around changing infrastructure. So changing record systems, that might be making changes to an electronic health record system, for example, or changing physical structure and equipment. And so all of these strategies may be used to implement a new practice or change clinician behavior. There's a variety on the right as well. So looking at facilitation, stakeholder relationships, supporting clinicians, and financial strategies as well. So there were a total of 73 implementation strategies identified in this paper. So audit and feedback is just one of a range of ways that we might try to change clinician behavior and increase uptake or fidelity or sustainability of a practice. So the practices that we're going to talk about today, opioid prescribing and CT ordering, are not new practices as such, but they are sort of target practices that may be changed with the use of these different implementation strategies. So just to define audit and feedback, so this is collecting and summarizing clinical performance data over a specified time period, giving it to clinicians and administrators to monitor, evaluate, and modify provider behavior. So you may be using this a lot already. You may not be calling it audit and feedback. That's just the term from sort of the implementation science field. But it is something that I think a lot of administrators and leaders and supervisors do, on a regular basis. So what does audit and feedback look like in practice? So it could be verbal or written. The important thing is that it's sort of data driven. So you're measuring an aspect of performance and then you're presenting that data in a digestible way back to the people who are, affected by it. So the clinicians in this case. So it could be verbal or written. It could be in person or asynchronous. It might be at a group level. So you may give data for your whole department, or you may give it on an individual basis to clinicians so they can see where they stand compared even to their colleagues as well. It could be given once off, so just a snapshot of data, or it might be provided on an ongoing basis. And the data might also be against benchmarks, so sort of from comparable, departments across the country or compared to peers within the same department. So we just grabbed some examples here of how audit and feedback can actually be delivered. So it's very variable, but it should be sort of very visually clear. You can use color coding to, identify whether someone's doing well or not so well. It could be numbers based. It might be often it's anonymized. So if you are being compared to peers, you don't necessarily see what, who's doing what, but you see where you fall on the curve. So on the bottom left figure, this is the kind of audit and feedback that was provided in our CT intervention. So just like we might look at the clinical effectiveness of an intervention for a patient, we can also look at the effectiveness of audit and feedback as an intervention for clinicians. And so the question is whether or not audit and feedback works. And there's this very extensive systematic review from Ivers and colleagues. It was a Cochrane review in 2012 to look at whether audit and feedback worked across a variety of settings and clinical practices. And so for clinicians' compliance with a desired practice, they located 82 comparisons that looked at dichotomous outcomes and found that audit and feedback increased compliance in dichotomous outcomes by 4.3% and in continuous outcomes by 1.3%. So not really huge numbers there. And then on patient outcomes, so, sort of looking at audit and feedback on the more distal outcome of patient health measures, they found 12 comparisons sort of no effect on dichotomous outcomes, and a moderate effect on continuous outcomes as well. So that's probably the landmark paper in the audit and feedback kind of world to date. They did look
Oh, she may have frozen.
at some of the things that made audit and feedback. Sorry, can you hear me okay?
You froze up a little bit just as this slide came up.
Okay, okay. Can you hear me okay now? Sorry about that. Okay, great, thank you. So yeah, I guess one of the questions is, how does the audit and feedback actually work? Like, what is the theory behind?
Selena, think if you shut off your video momentarily.
So one model, yes.
And why don't you shut off your video, because that may actually help the bandwidth.
Okay, okay.
There we go.
Perfect. I apologize, sorry. I
No
tested
worries,
this
it
earlier,
happens
but
a
it's
lot.
just showtime. Okay, thanks for letting me know. If I freeze up again or if I stop talking, please do let me know.
Okay, I can't hear you right now.
Oh.
Can you hear us, Celine?
Yeah, I think she's muted.
Yeah. We can switch up that.
Okay, is this better?
Much better.
Okay, is this okay?
Yep.
Okay, I'm so sorry. Hopefully that won't happen again. I'm not sure what's going on. Usually my internet is fairly reliable. Sorry. Okay, I'll just keep going, and if I stop, please let me know. Okay, so the theory of how audit and feedback works basically is sort of founded on the discrepancy or not between the data that's provided and the person's performance. So if a person is provided with positive feedback on their performance, then they will seek opportunities to sort of attain other goals. And so they sort of stop attending to the clinical practice that was being emphasized with the intervention. If they receive negative feedback on their performance, then they will increase their effort towards that goal, with the goal of reaching whatever the preferred performance was, and they'll maintain or increase that effort towards that goal. So this is the kind of model that attempts to account for whether or not the intervention is effective. So it seems like audit and feedback is more effective when the baseline performance is low, when the source of feedback is a supervisor or colleague rather than somebody else, when it is provided more than once, when it's delivered in both verbal and written forms. So if it's just verbal alone, then that's not as effective. But if you are able to combine, a written version with some verbal feedback as well, then that's very helpful. If it includes both explicit targets and an action plan. And prescribing seems to be better affected by audit and feedback interventions than chronic disease care or testing. So this is what came out of the systematic review that was conducted by Ivers and colleagues. Okay, so even though there's a lot of audit and feedback studies out there, few, if any, have examined whether clinicians' baseline perception of their performance affects the effectiveness of the intervention. So many audit and feedback interventions will simply, derive data about performance and then present it to clinicians without actually testing where their baseline perception of their performance is. So you can imagine, according to the theory that I showed earlier, if your performance is actually better than you expected, then it may be that the audit and feedback intervention is not as effective. Okay, so I'm going to pass now to Dr. Michael. Sorry for the tech issues. Hopefully that will smooth out.
Oh, thanks. One of the things that's been particularly exciting for Martin and me about working with somebody like Dr. Larkin on our team is having some of the additional expertise around things that we had as vague ideas in our minds, and to make them more explicit, to lay them out in a way that now actually seems intuitive about directions of effect and how the kind of human cognition overlays with some of the things that we've been trying and doing to give feedback to providers or to healthcare team members, has made it much more clear to us what some of the underlying mechanisms might be. And so our goal is to then, in the next couple of minutes, show you a couple of examples of how to translate what we just heard from Dr. Larkin into 2 different example studies. And fortunately with Zoom now, with the platform change, we should be able at the end to have a little bit more dialogue and kind of Q&A session. And our idea of having the 3 of us kind of on a panel together is to get experience from all of you as well at the end about discussion around other examples, other studies you might be working on, other places where you might have been a recipient of audit feedback, other things that you might be toying with or other ideas. To be able to put together some of the implementation science background, some of the couple of example study experiences, and just have more of an ongoing conversation with all of you around what's on your mind with the idea of audit feedback. So in this particular example, as Dr. Larkin kind of laid out, there's this remaining question about how much is the recipient's self-awareness necessary, and we thought that the idea of opioid prescribing was kind of an apt target for a lot of reasons. There's appropriate focus and also very robust data around opioid prescribing, and so made for a good opportunity to look at an audit feedback mechanism and address that question of how much does self-perception matter as well. So here's the citation. This is published in Academic Emergency Medicine a couple of years ago. And this is a multi-center trial, so we can go to the next slide, that was across 4 different EDs and kind of diverse practice settings, a more academic center, an urban center, a smaller community hospital, and then a more suburban community hospital. And you can see kind of the breakdown of annual visits there, and a diverse setup of prescribers. They're all part of a multi-specialty group practice, and some floated between sites, and some spent most of their time at any given site. Roughly 60% or so were attending level emergency physicians, and the balance were either emergency medicine residents or APPs in this study. The next slide, you can see kind of the layout of the study in general, which was that we looked at 12 months of baseline opioid prescribing data. There were a handful of outcomes for this particular study. It was the proportion of patients who left the ED with an opioid prescription in hand was kind of the primary outcome. And then also by provider, the proportion of any given prescription that was for an opioid, as well as looking at MMEs, morphine milligram equivalents by prescriber, and also normalized against number of visits and number of prescriptions that any given prescriber gave. Each prescriber was randomized, and the prescriber was the unit of measurement here, and the target of the audit feedback, to either get an intervention, which was audit feedback with kind of a twist thrown in, or control group, which was not somebody who received their own data and didn't get a formal audit feedback mechanism of seeing their own data, but was subjected to what you might call the usual background messaging. In other words, they were out in the world hearing all of the broadcast communication about here are opioid prescribing guidelines, and here are ways that we can think about opioid stewardship in the emergency department, but didn't specifically get their own prescribing data. But in the intervention group, in addition to all of that background messaging, they had an audit feedback sort of mechanism of a data-driven intervention that we'll look at what that looked like in a minute with the specifics. But before providing them with their data, had the added step of a quick question: where do you think you are before I show you your data? Where are you? And then immediately getting the real answer to that question of where do you fall relative to your peers in this particular case for those outcomes that we mentioned. And then there was 12 months of post follow-up with those same outcomes over time, looking at the groups in the control and intervention respectively for what happened. So on the next slide, you can see an example of what they got in terms of the audit feedback tool itself in this particular study on the left. And before actually seeing the real numbers, before seeing you are here with 15% of your patients getting opioid prescriptions, you're at the 89th percentile, they got just the background graph that didn't have the bar highlighted and didn't have their information on it. And were asked the question, here's the group of all of your peers, you are one of these bars. And in terms of opioid prescribing relative to your peers, where on this distribution do you think you fall? And immediately after answering that question, got a depiction that looked like this, that showed them where they fell relative to their peers. And interestingly, a large majority of attendings and a much smaller proportion of residents underestimated their own opioid prescribing rather considerably. And that's an interesting finding in itself for a lot of reasons, but particularly germane to the topic of audit feedback, led us to kind of an interesting question about whether that group was maybe more susceptible to the intervention in the first place. And so on the next slide, you can see over time, here's on the y-axis, the decrease in opioid prescribing. So everybody starts at 0 baseline prescribing, and then at 6 months and 12 months, the line on the bottom, and hard to see on the slides, we're talking about a magnitude of change that's about a 5 percentage point reduction in proportion of patients who go home with an opioid prescription. In other words, an absolute risk reduction kind of 5%. The people who underestimated their prescribing and then were immediately given the real answer and had the experience of, wow, I'm actually prescribing more than I thought I was, had larger magnitude decreases at 6 months and at 12 months compared to either the controls, those are the people who just got the background messaging, or the people who didn't have underestimations, who got audit feedback, but had more accurate self-perceptions, which was particularly interesting. And those were changes that were sustained over time, and they held across many of the outcomes. The proportion of patients who went home with an opioid prescription in hand, but also morphine milligram equivalents prescribed, and some of the other secondary outcomes. And so on the next slide, we kind of lay out what we think is happening here and why there's implications for how we as a research community and how we as a clinical operations community or an implementation science community should maybe be thinking about audit feedback a little bit differently, which is that background messaging, broadcast communication, like, hey, let's think about opioid stewardship, that may decrease opioid prescribing in this case, and it seems like it does. And audit feedback might be particularly useful in a population that's more susceptible. And in this case, it was that group that seemed to have an inaccurate self-perception. And then when given audit feedback data, their own prescribing data, created some cognitive dissonance for them about, wow, it's not where I thought I was. And it might actually be that experience that results in the larger magnitude decreases, not the mere fact that they were given their data. Because as we saw, the people who just received their data and didn't have that experience of dissonance appeared to actually be similar to the controls in this particular study for this particular outcome. And so it led to kind of the natural question of, wow, I wonder if this effect holds in other realms other than opioid prescribing, which leads us to kind of example 2, and then to kind of the larger context. So I'll turn it over to Dr. Resnick for how to translate this into kind of the next example.
Yeah, thanks. Just want to pause maybe if there was any comments or thoughts, just because it sounds like with this new Zoom link, we could take time for that. All right, and feel free to interrupt me. I won't be offended, quite the opposite. Look forward to it. So I actually have, I lucked out with the shortest piece of this presentation. So fast forward 2 years later, after the opioid study had been done and published and moving on. And so in our department, we were faced with an issue that's probably common out everywhere. We had huge variability in CT utilization amongst providers. And I suspect that that's true for all of you at all your shops. That's out in the literature. And it's not just within, it's not even just within the institution, it's across institutions as well. And even on the ones that are fairly well published data or best practices are published out there for head CT, C-spine CT, chest CT, et cetera. We still saw variability. In fact, I think there's a couple posters out there during this SAM session about that issue and dealing with it. So, so flashback to 2 years ago, I said, oh, wait, we have a great mechanism to potentially take care of this, right? So opioid prescribing, we knew we had variability and we wanted to reduce opioid prescribing. And CT utilization, we have huge variability. And in theory, we want to reduce it because we think that there is over ordering of CT scans, not following guidelines. So as you're all aware, I mean, there's a sense of urgency related to CT utilization. Obviously, it's been fairly well published among standard guidelines out there, potential risk of cancer risk long-term in a lifetime from unnecessary radiation exposure. There's huge flow implications for us in real time. And there's also potential safety or financial implications as well for the organization. So we look back to the prior method. If you could fast forward on the slide, we look back to the future, so to speak. And we wanted to implement a methodology nearly identical to the opioid study because it had been so effective for us. It was a similar study setting. In the interim period, we'd actually taken on one more ED. So there may have been slightly different cultural makeup of the providers there, but it was a 45,000 visit ED, sort of fit within our spectrum of EDs that we had studied on the first one. And we had a similar study population. There was fairly low turnover in the group between studies, just due to some issues related to both EPIC and being able to pull out the data, as well as the fact that we felt that CT utilization was probably more driven by attendings. We decided to just focus on attending physicians. And it was also a piece of the paradigm was how APPs practice in our clinical environment. They were ordering fewer CTs on their own anyway. And the residents we felt more likely were probably driven by attending preference as opposed to opioids. So essentially similar study population, although it was limited to attending physicians in the study. So what we did is similar methodology, 12 months of baseline data collected out of our electronic health record. We, rather than sort of baseline background, we did have a one-time didactic session for all subjects. And so this, both control and the audit and feedback arm received this. And it was based on not a fairly brief presentation, but it took up staff meeting and residency lecture related to what are known best practices across the country related to certain CT scans, and also the data that is available and published, or at least expert opinion related to potential long-term mortality risk related to unnecessary radiation. And similar, the same methodology of sort of the audit and feedback, and I'll show you the depiction in a second. I think, Celine, if you, it's on this screen, it'll show up. Similar methodology, we upgraded to color on this one, but it's the same principle. There's the distribution of your peers, and we asked them to guess which one, or to estimate which decile they thought they were in, and then a research assistant then presented them with that information verbally as well afterward and showed them where they were. In this case, and I can't recall now that I sit here and think about it, but we did a 6-month follow-up on this rather than 12 on this study, but otherwise similar methodology. So implementing this is what we found. And so as you can see, both groups actually increased their CT utilization, which was just exactly opposite of what we had intended. So it's like if you hit the button, it was, as you can tell, it was an epic fail. And so we sat there and we said, okay, we failed. And the question, what's interesting about it is begin to think about why. And this is part of what sort of led to this talk and combining it with the opioids and Celine's expertise on this. So if you fast forward to the next slide, so what happened here? There could absolutely, and our study methodology couldn't rule this out, but there could have been some unmeasured perception of sort of high stakes for under ordering CTs that went on. And we believe that that's true. And it probably affected both groups. We're not aware of any cultural shift that happened over the study period, but it is different than opioids in some sense. I mean, opioids, there was a mandate in the state. There was a little bit more higher stakes. If you were doing it, it was observed closer. If you over order a CT scan, there's less immediate sort of risk to you and the patient, and it's probably delayed. So it is slightly different than opioids in that fashion. But one of the things we did is we dug back into the data. It showed up in the next data set. Is what was interesting about this group when we went back and looked at it. In this case, the group, their self-estimation was actually off by quite a bit, 3 deciles. I mean, to orient you to the slide, the actual, so this goes from 1 to 25 ordered in CT utilization decile going down the way. And then the blue lines are what they estimated their decile would be. And you can see the difference. And the key here is that 60% of our audit and feedback cohort actually overestimated their ordering behavior. In essence, they thought they were worse than they were when they were presented the data. And we believe that this is a fundamental piece to what's going on in the background. Although that can't be definitely determined from our study methodology, we think it's an important thing. And as Celine will get into in the next couple of slides, is we think that this is very important in how you design audit and feedback. So if you flip forward, Celine. So when you think about it, it's intuitive. If you're presented with data that you're not nearly as bad as you thought you were, then you're not going to be as driven to change, okay? And so Celine is going to be give you a much more sort of scientific or sort of less colloquial approach to that. But it makes sense, right? If you go into it in Sean's study where, oh my God, I'm much worse than I thought, you're going to have some motivation to change. And if you're actually better than you were, you could probably have the opposite effect.
Thanks, Martin. Okay, so just to kind of wrap up what we've been talking about and interpret some of our findings, we are curious to know why the same intervention would have such different outcomes in the ED. So in the same ED. So one of the potential reasons could be that the target behavior was different. So like you mentioned, Martin, so CT ordering versus opioid prescribing, two very different target behaviors. And we know from that IVR's systematic review that prescribing is more sensitive to an audit and feedback intervention than ordering behavior is. So it may be a function of the target behavior. The baseline performance may have been different between the two studies, potentially turnover in the years between the studies, but like we mentioned, it was only about 10% turnover, and the culture of the emergency department didn't change a lot in that time. So that's probably less promising as an explanation. And really, we kind of started to hone in on those baseline perceptions and the fact that in the CT ordering study, people really tended to overestimate their CT ordering behavior. So they may have been less amenable to change. So if we revisit this feedback intervention theory and think about like which direction did each of the studies go in, with the opioid prescribing study, the feedback that people received on their individual performances tended to be negative because they were starting from the point of more so underestimating their opioid prescribing behavior. So once you show them that discrepancy, then you can encourage them to change their behavior so that they're more in line with where they want to fall on that, especially in the context of those important kind of public health messages that were coming around opioid prescribing. With the CT ordering, we anticipate, like Martin said, that people really were, when they found out that they had actually underestimated or overestimated their ordering, then that was sort of positive feedback, actually, that I'm not doing as badly as I would have thought. And so the energy and the cognitive kind of effort goes towards other goals, and they really don't try to change their behavior as a result. So I guess there's a few kind of practical implications for from this study, or these pair of studies, and we're going to definitely sort of do a little bit more research, I think, with other target behaviors and look at other contexts for this. But we would say if you are considering using audit and feedback, and this may be more so just in the run of kind of quality improvement efforts, or other ways in which, you know, clinician behavior might be you might be trying to change clinician behavior, seriously consider what the actual baseline performance is for your group. So where are they falling in relation to the preferred performance, but then also their perceived baseline performance, and then decide whether to give feedback to participants or to clinicians. And you may decide that there are certain clinicians whose baseline perceptions will drive whether or not they should actually receive feedback at all. Because if you give them feedback in the unexpected direction, then you might sort of shoot yourself in the foot. So it does, the results really underline the importance of understanding physicians' self-perceptions of their performance before you implement the feedback portion of the audit and feedback intervention. So it's not a panacea for changing clinician behavior, even though it might be a convenient and routine thing to do. You might want to just consider where the baseline perceptions are before implementing this intervention. You could potentially tailor how data are presented, to whom data are presented, and consider really whether audit and feedback is the most appropriate intervention for a particular practice change. And again, it might depend on the target behavior as well, knowing as we do now that prescribing may be more, you might be more successful with an audit and feedback intervention for prescribing than for testing. So we'd be interested to explore the accuracy of self-perception of clinicians around a broader range of targeted behaviors. So even without delivering an intervention, just do some more baseline sort of survey work on other types of imaging, screening, guideline adherence, referrals, and look at the potential moderating effect of baseline perception on the effectiveness of audit and feedback with a larger sample as well, and potentially in other emergency departments too. So I think we'll open it up for discussion at this point. I might hand back to Dr. Gautreaux.
Yeah, so there are not too many, not an overwhelming number of folks. So if anybody has a question, just feel free to unmute yourself and ask away. I've got a couple myself that I can break the ice with. And I think, Celine, one of the first ones that you mentioned early on, you mentioned A&F in either a group setting or individual. And in a lot of departments, they do tend to do a lot of group, data sets, which, how useful is that to practitioners, especially in large groups where we don't know where we sit in
Right.
that data set?
And I would hazard a guess to say that we usually think that we're the ones who are doing a great job and other people are letting the side down. So it seems like, that sort of individual feedback can be a bit more powerful because you start to challenge some of those, sometimes not delusions is strong a word, but inaccurate self-perceptions that people have about their own performance. I think it's, I guess the group level feedback can be helpful for, I guess, fostering kind of a team approach and team problem solving to the issues. But I do think in terms of its effectiveness, I would say the individual is probably slightly more effective.
Have you noticed a reluctance on the part of ED leadership sometimes to give the individual feedback, just because it can be perceived as awkward, or worse, you get it once a year during your annual review?
I might pass that to Martin, if you don't mind.
Well, an interesting, deeper question to it is when you're giving feedback about individuals to the group, do you make it anonymous or not, right? So you can show the group distribution, then tell people quietly where they are on the distribution. I've seen that employed. We've tried it for different things in our department. The bigger question is there more effect if you make it public? So to speak, the shame slide, right? Like, I'm not advocating for either one bluntly. There's positives and negatives, I can imagine. I sort of lean away from that. But the bigger question, I don't know if there's data out there that shows this. You could also engender some pretty negative, sort of unintended effects in other categories. You may improve that behavior, but you might piss off somebody significantly to not want to do it the next time, kind of deal. So I don't know. You're opening, you're opening Pandora's box with it. The other thing is I sat here and listened to Celine much more eloquently say that what I was trying to. The question is what we're saying is it's hard to do in some sense. How do you ask somebody for their feedback and then delay whether you're going to tell them what their actual outcome is or not? And so I think we're scratching the surface of how to do that appropriately. But the point really is you may actually shoot yourself in the foot if you don't understand who your audience is and what data you do present to them. And that's why, even though that second study isn't a definite outcome, we thought it touched on a potential phenomenon that we think is real. So,
yeah, the idea of unintended consequences, I think, struck all three of us as the real impetus for doing this talk and having this conversation with a larger group of people who also think about this, which is why I'm particularly excited to hear from all of you who are have been listening in and have a little bit more conversation about it, because I think that, to me, it feels a little dirty in a way to use some of this cognitive psychology against people. It feels a little manipulative to try to decide in advance, I'd like to adjust behavior in this particular direction, and therefore I know that for the people who are doing it really well, I have to be very careful, or for the people who might be overestimating or underestimating or have inaccurate self-perceptions, but in the opposite direction compared to what I would prefer, I have to be very cautious. But I think it, whether or not it feels manipulative, useful, savvy to you, I think the overarching theme of it's a lot more nuanced than just give them their data. struck us as a kind of an interesting conversation point. And I think scratching the surface is the way that I'm thinking about it also, right? We know enough background. We have a few examples. There are other examples out there too, but I think the idea of unintended consequences is an important one for us to keep in mind. And particularly for self-perception, you don't actually know what people's self-perceptions are until you ask them. And that's logistically much more difficult, as Martin alluded to, than simply just posting a slide or giving people an email that says, look at a dashboard or here's your numbers. And doing it that way potentially creates a lot of consequences that might have the opposite effect than we think.
Right. I think that's such an important point, Sean. Sort of, you don't know until you ask them. There had been one previous study that looked at self-estimates of physicians in the emergency department around CT ordering, and they had the opposite inaccuracy. So those physicians tended to underestimate their CT ordering. So if you based your audit and feedback intervention on that previous paper and say, oh, physicians often underestimate their CT ordering, you wouldn't have known what our physicians in our context understood to be their behavior.
Yeah, no, I want to emphasize that. One of the things that I believe to be true, it's highly based on your local culture in some sense, right? And you may even have subcultures that you don't even know about. So it gets, I think what Sean is saying, I want to reiterate, I kind of went into this stuff. I don't know whether he did, but I went into this stuff thinking that audit and feedback was this panacea, it's going to solve all your problems. It's very easy to do. You can collect data nowadays and present it to people, right? I'm super savvy. Well, guess what? You're not. If that's the case. And I guarantee everyone that's on this call, their department has tried this in one format or another and didn't realize that there's potentially unintended consequences.
Yeah, and so many confounding variables. As you mentioned, the culture of the institution. I moved from one institution that had your institution that had was focused on reducing CT usage, to another institution which quite does not try to reduce CT usage, quite the opposite actually. And adjusting to that culture is often difficult for people who move from one institution to another. Then of course, the pressure placed by other services, admitting services to do tests which may not be necessary, just to get the patient moving out of the ED.
And it spans beyond even just that, we've used some kind of clinical operations or care delivery kind of examples, but I think this phenomenon probably spans beyond just the clinical realm too, right? So we provide people with their resident evaluation data. We provide people with a lot of other kind of academic performance data. And we try to do group norming in those realms as well. And I think that there's a potential that we should be thinking about it in a little bit more sophisticated way, even outside of just the direct clinical care realm.
Absolutely.
I'll add one more layer to this. I haven't thought this out, but just listening to all of us talk a little bit about this, if you're trying to reduce the standard deviation around the mean of that group that you're showing, I have to think about this some more. That's different than trying to shift the mean in some sense, right? And so your techniques for both of those could be different in this regard, and I'd have to go back and think about it more. But again, it's just as you peel back the onions on what we thought was just a very easy way, show the docs, anybody their data, and you're going to change behavior the way you want it to. Well, not true.
Yeah, Martin. Along those lines of kind of the difference between shifting the curve versus narrowing it, I wonder if part of the difference between the outcomes of these two studies too was also just how clear the right directionality is for movement here. I think certainly at the time of the study, I think, even folks that were on the lower end were probably in agreement that less opiates is better. We're in the middle of a, pretty significant opiate pandemic in the region with seeing lots of overdose death and things. But CT, on the other hand, although maybe people might say they want to reduce CTs, I think a lot of folks feel like they're doing CTs when they should be doing CTs. And giving them just the raw number of how many I do, they're going to say, however many that is, they're the right ones because I'm using my clinical skills to decide whether to do that. So perhaps moving to a less CT is not necessarily what everyone would consider as the right goal. but giving them something else perhaps that would be more generally accepted as correct, you know, in terms of other metrics related to CT utilization, whether it's percent positivity or, you know, adherence to guideline, that kind of thing, could provide a more clear directionality of movement. And then maybe you might not see that difference.
About 5 minutes left. But what you said, Kevin, brought up a question that I actually had for Sean with respect to the opiate prescribing patterns, and it actually could have some impact on CT prescribing patterns. But did you look at the data with respect to clinician age? So, for instance, you know, many of us who are older, you know, started our careers at a time when we were intensely pressured to increase our opiate prescribing because we were told that we were being very, very mean, and that pain was the fifth vital sign, and you know, we weren't taking care of these patients. And it occurs to me that you know, as we refined you know, the need for imaging and moved to, for instance, ultrasound for appendicitis, that there may be similar age-related you know, variables with respect to both metrics.
It's a really good point, Mark. And I think it gets the idea of like the subcultures essentially, right, that you might not even know about or might not even think about. And in the opioid study in particular, we did look at time since residency and some other provider demographics, provider gender. There was a little bit of kind of a complex nonlinear association with time out of residency and the degree of misperception, but not with kind of the susceptibility to the intervention or even actually where people fell on the distribution. May have been related to the sample size of the group or a lot of other factors. But I think your point is a good one that gets the idea that it's more complex in even yet another way, which is each individual brings with them a set of experiences and implicit biases, and you have to work within that construct as well. And you might not know what those are, and they might not know what those are. And as Kevin kind of alluded to, it depends a little bit on how you frame the question a bit, or how you frame the outcome, and what you imply is the right direction as well. And as you said, Mark, what the right direction is, depending upon what we're talking about, might be different things to different people at different times, depending on where they came from. And yeah, it's a lot more complex.
We have about 1 minute left. If anybody has, you know, one last question. And if not, I want to thank each of our presenters. This was a fantastic talk, and thank you so much.
Thank you.
Thanks, everybody.
Thanks for being here.
Take care.